It attaches magnetically to the drill, and then once it's drilled into place, you're going to remove that stylet. Safety first. And then this proprietary dressing fits nicely over the top right there, and you can then connect your tubing, and you're all ready to go. For the proximal tibia, you want to feel 2 finger breadths below the tibial tuberosity, and you're going to go on that anteromedial surface. So you're going to prep the skin, of course, first. Now with your drill, here they're using the yellow one. The blue would also work. Yellow might be a little long, so you just don't want to hub it. You're going to advance it through the skin and then drill until you feel give. That's how you know you're in the medullary cavity. Don't push it beyond that because you don't want to go through the medullary cavity. Now you remove the stylet and you can place that fancy, beautiful dressing. And now you can hook up your tubing. So they're going to draw off some labs here, which is great for things like H&H and type and screen, but some of your elements of your chemistry panel are going to be very different from your serum levels, so you want to be careful. And remember, you can give any medication through an IO line. For infants and kids less than 6 years old, the proximal tibia is actually the preferred site. Here's some other options for placement. You can go in the distal tibia as well, and basically it's like the medial ankle, where the medial malleolus meets the shaft of the tibia. Another option is the distal femur, and for that you would go 2 finger breadths above those wide condyles of the knee, and that's right smack in the middle. And finally, there's the humeral head, and you're going to go in the greater tuberosity of the humerus. Now, if you're going to do this in an awake patient, then I recommend using some anesthesia, and you can use my mnemonic 2 of 2 for 2 times 2. That's 2 cc's of 2% lidocaine over 2 minutes, then do a flush and wait, and then repeat it, so times 2. 2 of 2 for 2 times 2. And that gives your patient 80 milligrams of lidocaine. Some people use a little more, a little less, but that's a safe amount. I also recommend anesthetizing the skin and periosteum before you start.
So in general, that is the typical IO that we're going to use. There are a couple other options that are out there. One of which is this sternal IO. This is super barbaric. This is on page 715.
The following video was recorded by the Strategic Survivability Research Group, 2SRG of Las Vegas, Nevada. The device used for this life insertion demonstration is the Ping Medical Fast Responder Sternal Interosseous device. This device is the hospital and pre-hospital version, and Ping Medical offers another device which is mechanically identical called the Fast Combat. The Fast Combat, shown here, is packaged and colored for military use.
It's black, that makes it...
The volunteer patient is a 32-year-old male in excellent physical condition. The provider deploying the Fast Responder Sternal Interosseous device is a nationally registered paramedic, and this is his first deployment of the Fast device. The responder received training prior to this insertion, which amounted to a 10-minute lecture and demonstration by a PhD medical researcher using the Fast Trainer device and SimStern material. This is not a training video, it is a live insertion demonstration. Therefore, for detailed instructions on how to use the Ping Medical Fast Responder Sternal Interosseous device, visit the Ping Medical website at www.ping.com. The skin surface was cleaned and dried pre-insertion using an iodine skin prep swab. Be sure to follow your medical direction and control requirements for pre-insertion sterility. For insertion, the provider uses the recommended techniques discussed in detail on the Ping Medical website. The provider locates the patient's sternal notch and aligns the sternal notch indicator on the target foot of the device and pushes on axis straight into the manubrium. This user-applied force will power the device to pierce the skin and seat the tip of the infusion tube into the cortical bone of the manubrium. Follow your medical direction and control for this next step. Before hooking up the IV line, it is recommended that you aspirate marrow and flush to clear the tip of the infusion tube. During aspiration and flush, patients sometimes remark of a low level of discomfort in the form of a quick visceral pinch. Once aspirated, the IV tubing and bag are connected to the infusion tube and the flow begins immediately. On a pain scale from 1 to 10, the patient claimed he felt only minor discomfort on a level of 3 or 4 for a second or two. Flow rates can be as fast or as slow as needed. While maximum flow rates in excess of 100 cc's per minute are possible, there is typically no need for such a high flow rate except in cases of severe trauma. The vast majority of EMS infusions, including cardiac arrest, arrhythmias, and most medical conditions, are less than 200 cc's per hour for a variety of reasons. However, as you can see in this example, a gravity-fed bag can flow at a very high rate. To extract the infusion tube, the provider grasps the tubing as close to the skin as possible, and while holding the target foot with the non-dominant hand, pulls back in a steady, continuous motion until the tubing and tip separate from the manubrium. For those who have done this, it is clear that a correctly placed infusion tube is not going to become dislodged during manual or mechanical CPR compressions. This is the insertion site 1 hour after insertion. You can clearly see the 3 bone probe insertion points as well as the central infusion tube insertion point. The site should be bandaged and protected against infection. The Fast Responder and Fast Combat sternal interosseous devices are precision engineered to remove the guesswork and complexity of IO use. Again, for additional information on these devices and others.
Yeah, nope. So a lot of the departments do have multiple different variations of these. I know that locally there are some of the departments that do have the sternal IOs. There are some that have an easy IO, which is basically the drill system. There's also some other ones that we can kind of talk about in some of the PowerPoint slides. But basically, at the end of it, the biggest take home is on the inside of the bone. It's kind of a spongy material. That spongy material is directly tied to the vascular system, and any kind of fluid that we put into the interosseous space is going to systemically be circulated. A couple of the caveats, they don't necessarily, the flow rates do vary based on the site. We did talk about total, there's the 3 main areas that we're going to start looking at for potential placement of these. Let me pull the PowerPoints back up here. So here's 3 of our main sites here. There's the humeral, which is basically the humeral head on the proximal side of the shoulder. And again, all of these we're going to do. The proximal tibia, or the tibial tuberosity, is the term. If you reach down and you feel just below your knee, you'll feel one more little bony prominence directly just distal to your knee. That is that tibial tuberosity. If you go slightly medial to the inside, you'll feel kind of a flat spot of that bone. And that flat spot of the bone is exactly where we're going to go for that site. And then there's a distal one that's just superior to the ankle. But again, we're not going to usually mess with that. With kids, you can do like the lower third of their femur. That's another option. But a lot of that is protocol driven. So just again, there's different sites. And likewise, there's different guns that we can use. So this is the Easy IO. Again, this is going to be a drill, and this is not exactly perfect placement either. You need more of an anterior approach into that humeral head, and we'll talk about all that stuff in lab. This is going to be the most common. This is that the proximal tibia, and then next to this is the sternal. So some of the indications, so a lot of times you don't want to start here. You're going to want to start looking for the peripheral venous access. So, all the IV start stuff that we just talked about. But lacking that, we can shift gears and try to go to this. A couple of the benefits, if you look at the leg, if you're working, a non-breather or code situation, that distal leg is kind of out of the way. People are doing chest compressions. They're all up at the head doing airway management. For you to be able to stay down towards the feet and do cardiac medication administration and stuff like that down there, there's some benefits to that. Statistically, there's a formula to decide what the bioavailability of the medicine is by giving it further from the heart than if it were placed in the humeral head or the sternum. And there is some data that would suggest that the lower leg does take a little bit longer. But again, we're splitting hairs at that point. So as far as just ease of access, logistically trying to keep you and your medication administration tasks away from the airway and the chest compressions, there's a lot of benefits to doing it this way. I know the video, according to the manufacturer, a sternal IO should not be affected. Again, the instructions say that it shouldn't be affected by chest compressions. But I would argue that I would challenge that. If you think about the way anatomically this works, you're placing a needle in a sternum, in the superior side of the sternum, and you're doing chest compressions on the lower third of that same bone. So by nature, you're going to move that. Any kind of movement in that thoracic cavity changes the pressure within the thoracic cavity. So if you start thinking about the actual physics of that, it's almost impossible for it to not be affected in one way, shape, or form. Now, the way the manufacturer suggests, the 3 needles down towards the bottom of that sternal IO that you see there, those are basically stabilizers. So it kind of stabilizes that needle system within some of the subcutaneous tissue there. And then when you push down, you actually you do that full pile drive, and you push that in there. That main bore needle comes out, and it does bury into the sternum. So again, there are some stabilizers that will kind of hold it there. But again, when you're doing chest compressions appropriately and you have appropriate depth and rate, there is a potential for that to kind of get in the way. Also, for the departments that have the any kind of automatic chest compression machines, any of those, obviously this can impede where that suction cup goes. And it'd be really, really questionable to be able to do that. And again, most of the manufacturers will tell you that that's probably not a good idea. Just a food for thought for that. These were
Adam,
yeah.
is this something we get to do in clinicals?
IOs. Yeah. So
if we have the opportunity.
Only if you volunteer. I'm in. I've got trainers. We've got all kinds of trainers that we're going to use for this. And yes, if you're doing clinical time in the field, this is, as soon as you get checked off on it, you're eligible to do it. You're authorized to do it. But you just need to demonstrate proficiency, and you need to be able to show me that you can do it. And then by all means, if the next cardiac arrest that you have during clinical time, when you're doing your actual clinical time, you would be eligible to do this. But again, there's a lot that's going to go into that. We'll kind of discuss some of the ins and outs of that a little bit later about the provider that you're working with has to feel comfortable and so on. But yeah, we'll take some time and we'll do that. This IO is a manual IO. You literally have to kind of give it a twist and a push to be able to get it to go into your site. The only time that you're usually going to see these nowadays, if your department has a Braslo bag, the actual trademark Braslo bag that has the rollout pouches, the Braslo modules, some of them do still have these in them. But overall, a lot of the departments are starting to move into the fast IOs or the easy IOs or some of the other ones. But there are a bunch of different types. Here's a one version of the sternal, albeit this is a little bit more barbaric looking than the other one. This has several of those stabilizing needles. And yes, we'll be able to practice with these. I do have one of these. Here's the easy IO. This is the most common that you'll see locally anyway. The 3 different needles that are there, again, the pink one, that is more for pediatrics. Now, the important thing to note is that the needle size, it does vary, but it varies more in length than anything. If you look at the bottom there, all needles are 15 gauge needles. So if you remember the chart, 15 gauge is a pretty big needle. That's a pretty big device there. But again, the difference is the length. So there's nothing that says you can't use the yellow on a pediatric. But you just have to know that if you actually put a little bit of pressure behind that drill, it's really, really easy, especially on pediatric bones, to drill all the way through both sides. So the video before had mentioned once you feel kind of the give or kind of the release in pressure, that's usually a good indication that you're in that interosseous space. So a lot of this is going to be feel, and I do have we've got a lot of mannequins that we'll be able to do this on, and you'll be really, really comfortable with this by the time it's all said and done. So again, going back to that, using the yellow one, you can do that, but you'll just have a lot of needles sticking out on top of the skin that you'll have to find a way to stabilize without going all the way through. Conversely, you can't use a pink one on an adult because it's just you're just not going to get the depth. You're not going to be able to get into that interosseous space with the pink needle. But usually the way we use them in the field, the blue is typically something that, as long as they're not obese, the blue one tends to do fairly well in the tibia. And we usually use the yellow one for either overweight, obese, or humeral head, because there's a little bit more tissue that goes in for you to actually make it into the interosseous space. And if you look real hard, there's little hash marks on these. And we'll talk about this in lab also, but Generally speaking, when you actually put this, when you go to physically use this, you'll put it on the drill after you sterilize your spot. You'll identify everything, you'll sterilize, and you'll take the needle end of this and you'll physically push it through the skin until it stops on the bone. You should still be able to see this hash mark. That would indicate that you have this much space. You've got the rest of that needle length to be able to physically bore through and into that interosseous space. If the patient is large enough with enough adipose, or they're just overweight enough that when you bury this needle in and you stop on the surface of that bone, if this hash mark is gone or buried because it took that much extra needle to get to the bone, you're not going to have enough to get into the bone. You'll have to go up a size. And these are very expensive. I think in the neighborhood of $115 is, I think, the last time one of our guys had mentioned replacing them. But yeah, they're expensive. That near $100 mark is it's a lot. So we albeit, we don't want that to necessarily get involved, get in and start affecting our care. But at the same time, we don't want to just open a whole bunch of stuff and use a whole bunch of stuff that we know might not work anyway. There are bone injection guns. We don't use these. These are spring loaded. Again, we don't necessarily use these very often at all. So I'm going to kind of skip ahead because a lot of this, we're going to get to some of the complications, because again, the procedure, we're going to do all that stuff in person. So there is a way for us when we're drilling in, there is a way for us to remove enough bone going through the surface of that particular, either tibia or the humeral head, that the hole is greater than the size of the needle in general. What that does is as you increase pressure, so you're giving a medication, or you're giving fluid into that interosseous space, that it's able to come back out. So that's a problem. If you bury the needle all the way through, and again, you go in one side and out the other, again, you've created a condition where fluid can escape into that interstitial space there. Osteomyelitis is another complication of us doing this inappropriately or ineffectively. If you don't practice the aseptic techniques and you don't actually clean the site appropriately, or you drop the needle on the floor and then you put it in, again, bacteria is going to start to grow, and there'll be an infection created in that bone. This is a very, very painful long-term treatment for this osteomyelitis. And certainly this can turn into a septic issue, and this can certainly be fatal. So this is actually a really, really big deal. The treatment is usually inpatient with IV antibiotics and stuff for this osteomyelitis. So again, nothing I want to put my name next to. So try to again, just do your best to keep that aseptic technique in the back of your head. This talks about growth plates. So if you go too close to the knee or too close to the shoulder without physically being in that anatomical spot that we'll show you, that this certainly can be an issue. You can damage that growth plate, which ultimately can create pain long term for these patients. Fractures, obviously you're drilling into bone, so there's a whole bunch of stuff that can kind of go into that. Overall, these have been proven to be very, very safe. There's not as long as you're doing them appropriately, there is still good prognosis with this. But because it's a little more invasive than the traditional methods, we still want to try those peripheral IVs first, if at all possible. The PE at the bottom is the same as the IV. If you introduce a bunch of air into that interosseous space, it's the same problem. Body doesn't typically like that, so that can cause some long-term effects. So the big thing that they were talking about with pain, with the IV or the IO insertion, again, inside that interosseous space, there's bone marrow. Bone marrow has some concepts of creating red blood cells. The marrow in general there's a whole lot of different stuff that goes into the marrow. That likes to be a closed loop system. Your body doesn't do super well with that bone marrow being displaced. So if you think about it, when you put that IO in somebody's leg and you start to push fluid in, that fluid goes in and interrupts that balance. It starts to overpressurize the inside of that bone. That is extremely painful to these patients. So in the video, you saw the guy say, it wasn't super painful, the actual insertion part. Literally, that's just the superficial feeling of nerve-ending pain that you have physically poking through the skin. Poking into the bone itself is not necessarily painful. Again, it's just the breach of the skin that is. what's really, really painful is when you're starting to displace that happy pressure on the inside of that interosseous space. So that's when they were talking about the lidocaine. Given a little bit of lidocaine, again, that kind of nerve that numbs some of the nerve endings that are inside that bone, and that sometimes helps. But again, for you to physically give them lidocaine, you're still introducing fluid into a space, which increases pressure, which increases pain. So just know that these are extremely uncomfortable. The patient is going to be extremely uncomfortable as you start to introduce fluid into these patients. Also, depending on where inside the interosseous space you land, if you're pretty close to the backside, so you haven't gone all the way through, but you're pretty close to the backside of that, or the bottom part of that bone. When you're trying to introduce fluid, it may not want to flow. In fact, it usually will not want to flow like an IV will. So for that reason, a lot of our ambulance services are carrying pressure infuser bags, which essentially is a blood pressure cuff that goes around your saline bag that you can pump up and increase the actual flow pressure into the bone. Because again, typically with the IVs, we're relying on gravity to allow. That's why we hang the bag kind of high. We'll allow gravity to kind of force that fluid into the vascular system. And as long as the pressure on the outside is greater with the gravity than the pressure on the inside with the heart and the venous return, then it's going to flow in just fine. Conversely, though, in the interosseous space, that pressure is already pretty high because, again, it's a closed loop system already. So sometimes it doesn't want to flow just with gravity alone. It needs a little bit of encouragement from a pressure infuser bag. And I like that they put a prosthetic limb on here. We probably shouldn't be doing IOs in a prosthetic limb. It's not going to get us very far. So that's really about it for IOs. What questions do you guys have? Any? None? None whatsoever? All right. So this is the fun part. This is the medical math side of this. So we know how to get stuff into the body. Now we just need to know how much. Now, the disclaimer on this, medical math in general, you can absolutely get lost in. There is a specific drip and a calculation and a shortcut and a trick and finger methods and clock methods. And there's all these terms that you're going to hear and that you're going to use. The correct answer is whatever it takes for you to get to the right answer in your head. So if you're a math person, you might find this really, really incredibly easy to do most of this in your head. If you're not a math person, then it's going to take you a lot of extra work to really try to get this down to a science so that you're not over or underdosing these patients. So just to kind of get into some of these, we again, I don't want to go back to the therapeutic levels, but again, the basic principles still exist. We're still going to give medications to elicit a desired outcome for the patient. To do that, each medication is packaged in different doses. Some of the doses are weight-based doses. Some of them are different based on pediatrics versus adults. Some of them in general, we have to know that, for example, there's two different medications that we carry that if you give both of them through the same IV, it can literally turn into chalk. Again, body doesn't like that. So that can be extremely damaging to the body. So knowing what medications you're using, knowing what the indications are, knowing what the contraindications are before you give them can greatly help you long term, and certainly it's going to help the patients. So being able to fully understand that stuff is going to be super, super important. All right, so a little bit of review on the math. If we remember very specifically, I'm going to jump around a lot because this is going to be something that we covered a fair amount of with the moving to decimal point and things like that. So again, we're going to move around a little bit, and I'm going to probably start actually with a video. But just in general, we are going to, so talking specifically about weight conversion. So in your book, I asked you guys to start listing some formulas down. One of them is the multiplication or the division by 2.2. Again, that is converting pounds to kilograms and kilograms to pounds. That is flat out a calculator. You just do it. Alex had mentioned the 10% rule. A much easier way to think about the 10% rule is to take every number, divide it by 100, and then, so let's say 200. Here, let me show you my screen here. All right. So 200 divided by 2 is 100. If you take the first two numbers and you subtract it from your answer, you end up with 90. So 200 lb is equal to 90 kilograms. So again, I'll do that a little bit slower, but that is a generalized way of getting to 10% easily. So let's say we'll just use, so 240 pounds. So 240 divided by 2 is 120 pounds. You take the first two numbers and you subtract it from your answer. You literally get your answer. So again, that's the 10% rule. You can do that in your head, and that's definitely a possibility. But again, not everybody is going to be able to do that. Otherwise, you literally the only other way to do this is to just take that calculator and do the 220 divided by 2.2, and that is how you're going to end up doing that conversion. All right, so the next thing is going to be we talked about moving decimal points and conversions. And we're going to practice this today. So 4 micrograms is equal to how many milligrams? So again, if you remember, you have to create this little chart in your head of the different units of measurement and which order they go in, so that you know if you need to go this way 3 spots or this way 3 spots. So with this particular example here, we know that we're going to take 4. We need to go to milligrams. We know that milligrams for micrograms goes that way. So we're going to put our decimal point where a whole number would be. 1, 2, 3. We're going to fill in our zeros, including the one at the beginning. And the answer to this is 0.004. So again, this is basic conversion of units of measurement. So that's pretty important for us to understand. And this shouldn't be new to everybody. We talked about this, and you guys have kind of looked at this. Shifting gears, the next couple things that we're going to talk about. And again, a lot of this is going to be individual based. If you guys have a hard time, I need to sit down with you, and we need to just go through some examples. I'm going to give you more examples than you're ever going to want in the form of worksheets. And I'm not necessarily going to require everybody to do all of them. I'm going to kind of trust that, you guys are, you're at a point where you understand that you have to know this, and not knowing this is going to be detrimental to your patients. So that is going to be extremely vitally important for you guys to understand. And if you don't, it's your responsibility to let me know as we move forward. So let's say, let's pick a drug. Let's say adenosine. If you look at the vial, and the vial says that there is 6 milligrams in that adenosine, and we're going to watch a video here that's going to break this down thoroughly. But what we need to know is how many mLs is that? So when you look at a vial of adenosine, you may see something that says 6 milligrams and 2 mLs. So that's telling you that every 2 mLs of fluid, 2 milliliters of fluid, you're giving 6 milligrams of medication. So the next conversion that we're going to need to do is we're going to need to figure out our concentration. So what is the concentration of this medication? Concentration, I need to know for every 1 ml, there's how many milligrams. And you literally just simply divide. So for this particular medication, there's 3 milligrams per ml. And I literally was just able to take the 6 milligrams, divide that by 2 mLs, and I end up with 3 milliliters. So 3 milliliters is the concentration of this particular medication. Let me do this. Let's do this again. So let's say Versed. Let's say Versed is packaged in 5 milligrams and 5 mLs. You would literally do 5 divided by 5, and you would end up with 1 milligram per milliliter. seems relatively simple. If the medication dose was 5 milligrams per ml, they literally did the math for us, and the information that we need is already there. It's 5 milligrams per ml. So before we can give, and where I'm going with this is, before we can give any medication, we have to be able to convert what's physically in the vial that we have on hand into every ml. We have to break that down into 1 ml. Again, that is called the concentration. So we have to figure out the concentration before we can do anything else. Just for visual purposes, let's do one more here. Let's say it was packaged, and this is not actually a thing. But again, if it was 8 milligrams, and 8 milligrams are in whatever 2 mLs. Again, 8 divided by 2, this should be 4 milligrams per ml. Now, that's not always going to be a whole number like this. It's not always going to be perfect. So that's where a calculator may be necessary. Something as simple as us saying 8 milligrams in 3 mLs. Obviously, that's going to be, you're going to need a calculator for that. So when you actually do that, you end up with the decimal point, and I'll go ahead and just do it here. Erase this. So the answer to that is 2.6. Oh, I said 2 and wrote 3. That's good. So 2.666, repeating. With medication doses, I do not want to go all the way up to 3 milligrams. I do not want to round up, because that is technically an overdose for that patient. With medication, we don't round. Now remember, with weight, we do round. We can round to the nearest whole number, but we don't want to do that with medication. Again, if we're to the point where we're physically measuring something out, it's because there's a reason for that. We can always give a secondary dose, or we can repeat the dose, protocol dependent again, but we can repeat the dose. But once you give them too much, you can't undo that. So for this particular one, it would be 2 milligrams per ml, and that would be the answer. Please, 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 please let me know if this is not making sense so far. Do we need...
Real quick, Adam, your first thing is to get how much per ml is on every single drug, correct? That's your initial...
The first part is to find your concentration. So you need to figure out the concentration, which the book likes to say is the amount that you physically have on hand. Because the Versed doses that we mentioned before, the Versed in general is one of the biggest issues with this, because packaging can vary dramatically. So Versed, you can find these in the field as in 5 milligrams per ml. You can find them in 5 milligrams in 2 ml. You can find them in 5 milligrams in 5 mLs. And then some of them you can find in 10. This is uncommon, but you can find it 10 in 5 mLs. So all of these are different things. These are all options that you can find from the manufacturer. And depending on who does your drug orders, this is, and your medical director, this is something that you can absolutely, you can see variations in. And that's, again, this is just, you have to be able to convert, you got to be able to convert this one, and this one into your ml, your actual ml dose. So again, for us to do calculations, you have to figure out what the concentration is per 1 ml. So that is the first thing that you have to do. So that's the first thing as it relates to calculating the actual meds. So we'll go through a bunch of different examples, but just at its core, I just need you guys to be able to look at this and know that the concentration of this medication, this particular medication, is 3 milligrams per ml. And if you got that figured out, that is step 3. So 1 was the weight conversion, 2 is the unit of measurement conversion, 3 is the concentration, which sometimes they also, like I said, they also like to say the on-hand dose, which is also, they'll do something like that in the textbook. But again, really all that is the concentration. So if you see a test question that says, what is the concentration? That is exactly what you're looking at here. Anybody have any questions? Again, if you have the question, everybody else does too. So just this is a good time to do that.
I did have a question about the 2.666 repeating. Can you round that down to 2.5? Or
Technically, yes. Technically, yes. How so where that becomes an issue, so 2.666, yes, that can equal 2.5 milligrams. If you're at 0.0254 something, 444 repeating or something, this is that one where you're going to have to round to the closest whatever you can get. And that's where, again, you never want to round up. So that's really what it's going to come down to, is you don't want to round up. What'll end up happening is, because there's going to be some confusion here, and there already is, and that's good, because there's supposed to be, your answers to this particular question, you'll have something like this, and it'll say very specifically, milligrams is actually what is the dose, what do you actually give, and it will be it'll be something like this. There's only one answer that's even remotely close that's correct. If this was 2.5, that would also be the correct answer. There won't be both of them, if that makes sense. You'll have, because again, medical math in general, we know that it's a sliding scale of stuff. We know that depending on how you're doing it and which formulas you use, once you get down deep into this rabbit hole of some of these, how many drips out of your macro drip set per hour that you're going to give, once you get way deep into this rabbit hole, there's going to be some fluctuation in answers. So it's always going to be, there's going to be one right answer that's in the ballpark of what you figured out. And I know it doesn't sit well with people that are, if you're sitting there going, God, there has to be like a definitive answer. There really isn't going to be, specifically with medical math. You're always going to be really, really close. And if you're really, really close, the next layer of looking at it is, do you want to round up or do you want to round down? And again, you never necessarily with medications want to round up. So that's pretty much the take home for that particular part of this lesson. So let me let's look at the book. The book goes over all sorts of stuff, and I don't really want to go real deep into that. What we're going to end up doing here, and this is just something that's going to benefit you guys. We are going to go when we get back into class. This is stuff that's not going to go away. You're not going to be tested on this right away. This is stuff that every chapter that we go into, we're gonna do some new version or some new variation of figuring out a particular medication and then the dose and then what route we're going to give it. So this is not a one and done chapter. This is a concept that you have to understand moving forward. So what that means today is that if you don't understand any of this today and this is all Greek, that's okay. That's not that big of a deal. We will absolutely be able to find a way to kind of get us to the point where we need to be with this. Does that kind of make sense? Any questions, problems, concerns with that? All right. So I'm going to show you a couple quick videos. These will be posted. I just found these last night. I was trying really hard last night to figure out what in the heck I can do remotely to show you the best thing I can show you for this. The one thing I do want you to know 100%, and it's worth reiterating again, is that this is a dynamic process of learning. I don't need you to go home today and be a master at any of this stuff. I just need you to understand the concepts, and we'll through repetition, we'll get it all figured out. So don't beat yourself up if you're not getting it. Math just isn't everybody's strong suit, and that's okay. All right, take a look at this. Pardon the corniness on some of this stuff, by the way. So in general, we talked about this. We talked about how this works. We talked about moving 3 decimal places. That's pretty self-explanatory, all things considered. They do a couple shortcuts as it relates to multiplying by 1,000, stuff like that. If what works already works for you, then continue to do that. Don't worry about all these other little tips and tricks and weird little nuances. Again, if it works for you, it's going to work in general. Here's how it does. So who wants to take a crack at this?
4.
There it is, 4. So here's another layer of complexity for us. So you have to give 4 mLs of fluid. You have to try to figure out how much one of these can take. And these are the 3 common sizes that you're going to see. You'll see 1 ml syringes, you'll see 3 ml syringes, and you'll see 10 ml syringes on your ambulances. And believe it or not, this gets messed up more than I'd like to admit. Specifically with there's medications like Zofran. Zofran can easily be given in two different syringes, depending on the dosage you're gonna select. But one dose requires one syringe, and one dose requires the other. So again, just thinking ahead of how much fluid you're actually going to need, and trying to communicate that with your partner who's actually digging through the bag to get you the syringe that you need is pretty important. All right, so this is where we shift gears. This is next. So now we're adding a weight-based calculation into this. So we're adding a layer of complexity to this. So if your your order is 1.5 milligrams per kilogram of lidocaine to a patient that weighs 155 pounds. So 155 pounds means absolutely nothing to me whatsoever. So we can, he's going to work through this, but based on what we learned before, you have to calculate a kilogram. So you have to convert pounds to kilograms. You have to find your concentration, which in this particular case, your concentration is 100 milligrams in 5 mLs. So for every 1 ml, how many milligrams do you get? 20. So if this doesn't make sense to you, again, write down your questions and see me either in private or now. So you figure out what your concentration is. You're told to give this. So this is how he's going to try to figure it all out. So again, he did this the second way that we talked about today. You could simply divide by 2.2. So far, hopefully everybody has kind of followed along. So for every 1 kilogram that this patient weighs, they need 1.5 milligrams. We determined that we figured out what the kilograms were before. It was 70, whatever it was. We multiplied that by the 1.5. We figured out what the concentration is, which is the 20 mLs, and we're literally going to divide from there. So the dose ordered divided by the dose on hand. That is a good formula to write down. So the dose ordered divided by the dose on hand. So what I want to mention with this, so if you're writing stuff down, let me go back to my screen here. Whoops, sorry. Which is also the concentration. So that is how to figure out how much you're actually going to give. Now, what the added level of complexity that lidocaine gave us was it was the order dose times kilograms. This is what he did. He actually took the order dose of the medication that we were given. We figured out that was 105. So order dose was 105 milligrams times whatever his weight in kilograms. Anybody remember what the weight in kilograms was?
70.
So we'll call it 70 kilograms. Whoops, here's where I messed this up. So the actual dose was not that was a step further already here. Let me go back to the actual. So it was 1.5. It was 1.5 milligrams. This was the order dose. 1.5 milligrams times 70 kilograms divided by the concentration, which was 20 mLs or 20 milligrams per ml. So this is the math formula that he did to end up where we ended up getting. So so far, is this making sense? I think you need to make sure. So this, let me go back to a different color here. So this top line is the 105. So it's just this times this equals 105. And 105 is divided by 20, which equals 52.5. Does everybody see where the math is physically going here?
It's 5.25, Adam.
Oh, yep. There you go. All right. Everybody see where the math is going here? All right. And again, we're going to have tons and tons and tons of time to practice this, probably in a method that's not necessarily over a Zoom meeting, because again, this is not the ideal way for us to necessarily learn this stuff. So let's go back to the video for a minute. Okay, so now we're just trying to decide how much we're going to give over a maintenance, is basically a maintenance dose. And that's what he's going to be covering here. And again, all of this is in your book. All of this is something that we really just individualized. We'll need to sit down and we'll make sure that it all makes sense to you guys individually. Let me just a sec here. Oh, Mr. Woodell just joined us. That's cool. All right. So again, this is figuring out how many drips per minute we need to run this. If we're looking for this particular dose with this particular drip set, which again, this was that micro drip set, and this is our solution or our concentration. So they asked for 200 milliliters per hour. Our drip set is 10. That's a formula that you can write down. And again, a lot of this is understanding the formulas, how to apply them, and then being able to pull them back out to figure out a problem. So as we're writing this stuff down, if you're looking to figure out how many drips per minute you need, this is the formula you need. If you're looking to figure out how many kilograms a pound is, then you know the 2.2 formula from before. That's the one you're supposed to use. If you're looking for the concentration formula, we know that that's the concentration dose divided by the milliliters that it lives in. So that's these. Again, we're just formulating our little toolbox here of all of the different formulas that we're going to end up needing. So dose times the drip set. And again, the drip set is generally going to be the 10 unless we're using the micro drip set, which is the 60s. So again, 10 and 60 are the two common ones that we're going to use for this drip set. So again, he rounded down because it's medication that we're given. Hopefully I'm gonna let that sink in. Hopefully everybody generally gets that. Again, you may not be able to practically apply it yet, and that's okay. Skip this in your brain. This is a shortcut again that is just going to confuse us. So let's not worry about that. So the last thing is, how do you figure out how much fluid to bring with you during transport? Again, this doesn't matter to us per se. So simply put, if you need 200 mLs per hour and you're transporting for 6 hours, then you need 1,200 mLs of So for every 1 ml, or I'm sorry, for 100 mLs, you have 100 milligrams. So it'd be safe to say for every 1 ml, you'd have 1 milligram. Anybody argue that? So that's pretty straightforward for that. What questions do we have for this so far, other than just needing repetition for it? Okay. Here's what we're going to do. And I'm going to see if this works the way I want it to. Of course not. All right, everybody have a, does anybody not have a phone that they can take a quick picture with? Or a screenshot or something? Okay. I need to find my cursor here. So I'm gonna break you guys into groups again, and you guys have to figure out some of these. Can you guys, yes or no, can you guys see this? Yeah, hopefully.
You zoom in just a little bit to it.
Yeah, just a sec. Technology is great, isn't it? So fantastic. Mm-hmm. Apparently not. No, apparently not. Here, stand by just one. Give me a minute. Do. If you're gonna take a quick 5 minutes, I'll get this figured out real quick, and I'll be you guys can jump into your groups. Like I said, if you guys did get a copy of this, give it just a minute before you start working on it, because I want you guys to work together on these. Did anybody get a chat picture?
I did not.
I got it.
I got it. You have to save it and then open it up on your computer, but it worked for me.
Okay. All right. All right, cool. So basically, like I said, just work together on these. I'm going to throw you guys in some groups, just randomized, and then we'll just kind of work through them. And I'll give it, I don't know, 15, 20 minutes, something like that. Do as many as you can, and then we'll kind of go through them together just to make sure we kind of got a grasp on it. Everybody good with that? Cool. All right, I'll see you guys in just a few. God, stop.